Welcome to The Explainer. Today, we're unraveling what is honestly a massive, hidden paradox in modern medicine. Just imagine for a second that the very medications you rely on to manage chronic conditions, the exact ones that are literally saving your life, are actually secretly starving your body of essential micronutrients. I know, it sounds like a total contradiction, right? But it's a physiological reality happening inside millions of patients right at this very moment. We naturally think of our daily pills as our protectors. But what if incredibly common medications for things like blood sugar, heartburn, and fluid retention are actually covert thieves, just sneaking vital nutrients right out the back door while you aren't looking? It really creates this compelling medical mystery. You take a pill to fix one problem, but the physiological changes it causes, whether that's in your gut or your kidneys, inadvertently create a brand new deficiency. Okay, let's dive right into this. The specific field of study we're looking at today is called pharmaconutrition. Basically, this is the study of how medications inadvertently cause dangerous nutrient deficiencies and, crucially, the evidence-based solutions we can use to fix them. We're going to put three massive, globally prescribed culprits under the microscope today to see exactly how they operate. Culprit number one, Metformin, the hidden B12 drain. So how exactly does this theft happen? Well, Metformin doesn't just do one thing. It's practically a coordinated blockade, attacking B12 absorption across multiple pathways. Primarily, looking down at the distal ileum in the small intestine, Metformin actively interferes with the calcium-dependent binding of the intrinsic factor B12 complex to its receptor. Without that binding, B12 simply cannot be absorbed. On top of that, Metformin alters small intestine motility. That can actually lead to bacterial overgrowth, which just further inhibits absorption. It's wild. Now, you might be wondering who is most at risk here. The severity of this B12 blockade is actually highly dependent on the dose. The data clearly shows that taking more than 1,500 milligrams of metformin per day significantly raises the risk of developing a serious B12 deficiency. In fact, for every single gram increase in your daily dosage, the risk literally more than doubles. But wait, it's not just about the dose, it's also about the duration. Taking these higher doses of metformin over a period of 4 years is the real danger zone. That long-term use slowly but surely depletes the body's B12 stores. And because B12 is stored in the liver, it can actually take years for the deficiency to show up. So this nutrient thief is definitely playing the long game. This brings us to what is honestly a massive clinical blind spot. Traditional laboratory cutoffs define a B12 deficiency as having levels less than 148 picomoles per liter. But evidence-based cutoffs show that borderline or marginal deficiencies, where serious clinical consequences actually start to happen, occur anywhere below 300 picomoles per liter. So, a patient might be told their labs are totally normal when their body's actually starving at the cellular level. And here is the truly tragic twist of the metformin B12 drain. Vitamin B12 is absolutely crucial for neuroprotection and DNA synthesis. When it's gone, patients develop neurological symptoms, most notably peripheral neuropathy, which is that tingling or burning sensation in the extremities. Now, a patient might feel this tingling and just assume their diabetes is getting worse, causing diabetic nerve damage. But in reality, it's not the diabetes at all. It's the medication stealing their neuroprotective B12. Crazy, right? Moving right along to culprit number two, proton pump inhibitors, or PPIs. The calcium conundrum. The mechanism here is simple but really profound. A normal stomach is highly acidic, usually with a pH closer to 1. But PPIs raise that stomach pH closer to 7, making it essentially neutral to stop your heartburn. While that feels great for your acid reflux, that extreme acidity is actually biologically required to break down and absorb certain vital insoluble nutrients, and the big one here is calcium. The sheer irony of how we treat this is fascinating. Think about calcium carbonate. It's cheap, it's heavily prescribed, and it's widely subsidized. But it's an insoluble salt. It absolutely needs a highly acidic pH to separate the calcium from the carbonate. So if a patient takes cheap calcium carbonate while they're fasting and they're also on a PPI, virtually zero calcium is absorbed. It's a complete waste of time, effort, and money. On the flip side, calcium citrate is a soluble salt. It doesn't need stomach acid to absorb at all, making it far superior for these patients. Yet, it's so often ignored just because it costs a little bit more upfront. That brings us to culprit number three, loop diuretics, the potassium flush. So, the way these drugs work is by aggressively forcing the kidneys to dump water, usually to clear out dangerous fluid buildup. But, the body isn't a perfect machine. When you open the floodgates to flush out all that excess water, you drag essential electrolytes right out the back door with it. The primary collateral damage here, massive losses of both potassium and magnesium. And this nutrient flush is definitely not just some minor inconvenience. Pushing all that potassium out of the body leads to a condition called hypokalemia, because potassium is the specific electrolyte responsible for firing your muscles. And yes, that absolutely includes your heart muscle. This deficiency causes severe muscle cramps, profound weakness, and in severe cases, life-threatening cardiac instability. You're fixing the fluid around the heart, but you're literally starving the heart's electrical system of potassium. So, how do we fight back? Here is the blueprint, outsmarting the nutrient thieves. So the absolutely crucial point here is how we tactically counteract these medications. Let's quickly walk through the game plan. Step 1, for Metformin, get your B12 screened at least annually. If you're deficient, you've got to bypass the drug's gut blockade. You can do this by using intramuscular injections or sublingual B12. Alternatively, research shows high-dose oral B12 paired with calcium can actually reverse the malabsorption. Step 2, for PPIs, switch to calcium citrate so you don't even need stomach acid. Or if you absolutely must use calcium carbonate, you strictly have to take it immediately after meals to take advantage of that food-induced stomach acid. And finally, step 3, for diuretics, you have to actively replenish your potassium. If your kidneys are healthy, load up on dietary potassium. Think avocados, leafy greens, and coconut water to replace exactly what the drug is flushing out. Look, medications are absolute miracles of modern science. They are profoundly and positively changing health outcomes every single day, but they don't operate in a vacuum. Every drug has a physiological footprint. By really understanding pharmaconutrition, we can keep the life-saving benefits of our medications while totally eliminating the nutritional harms. So I'll leave you with this final thought to investigate. Take a look at your own medicine cabinet. What covert nutrient thieves might be hiding in there? And is it maybe time to have a highly informed conversation with your doctor? Thanks for joining me for this explainer, and as always, stay curious,